It's Patrick Hutzel from IntensiveCareHotline.com, where we instantly improve the lives for families of critically ill patients in intensive care so that you can make informed decisions, have peace of mind, real power, real control, and so that you can influence decision making fast, even if you're not a doctor or a nurse in intensive care. This is another episode of Your Questions Answered, and in last week's episode I answered another question from one of my clients. And the question in last week's episode was how to manage tracheostomy, confusion and seizures in intensive care for your loved one after a stroke. You can check out last week's episode by clicking on the link below this video. In this week's episode of Your Questions Answered, I want to continue answering the next questions regarding James and Christine's dad in ICU who's had a hemorrhagic stroke. James and Christine's dad had a brain decompression where they evacuated a large bleed from his brain after the hemorrhagic stroke. And their dad also underwent a craniectomy, which is basically a removal of the skull to decrease the brain pressures after the bleed. James and his sister Christine were getting their dad in one of the best hospitals in the United States, the Cleveland Clinic in Ohio. In the meantime, their dad was getting a tracheostomy because he couldn't be weaned off the ventilator and the breathing tube. He also had a PEG tube for feeding inserted. He also had ongoing seizures due to the stroke, and his anti-seizure medications needed to be optimized so he could wake up and progress to neurology rehabilitation. So in today's episode of Your Questions Answered, I answer the next question in a series of questions from James again about the day-to-day challenges his dad is facing whilst being in ICU. James also wants his dad to stay in ICU and not go to LTAC, which stands for long-term acute care. We therefore also discuss again strategies around staying in ICU for as long as is clinically needed. So today's consulting and advocacy session is another excerpt from various one-on-one email consulting and advocacy sessions with me. And the topic this week as part of this series with me and James is how to get best care and treatment when your loved one has seizures and is ventilated with tracheostomy. You can also check out previous episodes of this one-on-one consulting and advocacy series of questions with James and Christine if you're clicking on the links below this video. And if you are watching this on YouTube, just click on the link below this video. That'll get you to our website where you can access all the other episodes as well. So James writes, "Hi Patrick, my dad's glucose is 149 when standard range is 74 to 99. Please advise." So here is my response to this. Hi James, many patients in ICU suffer from high blood sugars during their stay in ICU. This is a stress response from the body because of the stressful critical illness. Stress releases cortisol, and cortisol increases the blood sugar. Furthermore, your dad might have been or might still be on steroids for the head injury to bring the swelling down in the brain, and steroids will increase the blood sugar as well. Most patients who are non-diabetic and have raised blood sugars during their ICU stay have their sugars back to normal by the time they leave ICU. The important bit is to know that it can happen for non-diabetic patients and that it simply needs to be managed. I hope that helps. Give me a call or email me back if you have any other questions. So here is James' response. Hi Patrick, my father seems to be very sedated again today from the Vimpat maybe. The ICU said this would be less sedating than the Dilantin, and Dilantin is also known as phenytoin. Now they are trying to wean him off it and just leave him on Keppra. The epilepsy team is doing this. What are your thoughts about it? Please advise. So here's my response. Hi James, do you know how much Keppra, Dilantin and Vimpat your dad is currently on, or how much he was on in the last few days? It would be good if you have the dosages, usually in gram or milligram. Also, when was the last CT or MRI scan of the brain? Do you also have a score for the Glasgow Coma Scale? Also, you told me that you never got a straight answer to your questions, and I'm not surprised about that. The intensive care team by now will be feeling pretty threatened by the amount of knowledge you have already gained in recent days through my one-on-one consulting and counseling with you and your sister. Don't let that stop you and keep asking the right questions. Knowledge is power only when you use it. Take still one day at a time and keep focusing on the positives, and also be prepared for some setbacks. Also, make sure you look after yourself first and foremost, as I can hear you're getting pretty tired. You are the most important person in all of this. Make sure you stay healthy, rested, and sane. Your father will need the best version of you. So, here is what James writes back again. Hi Patrick, my father had 5 clinical seizures last night. The ICU doesn't seem capable of controlling his seizures. I'm getting very, very concerned. Also, my father had the tracheostomy and PEG done today and is doing really well. Still trying to control the seizures. Dilantin was added back on yesterday. So, here is my response to this. Hi James, one of the challenges your dad is facing with the ongoing seizures is that they're trying to control them with Keppra, Dilantin and the Vimpat. This usually works once all of those medications have been optimized and are well balanced. The team of doctors and nurses haven't achieved that yet. One of the biggest challenges when managing acute seizure activity is not to keep your dad too sedated, especially since he now has the tracheostomy. One of the goals of a tracheostomy is to wean off the ventilator as quickly as possible. You may remember that when your dad was still having the breathing tube or the endotracheal tube, he needed to be sedated. So he was able to tolerate ventilation with the breathing tube. To a degree, that also prevented seizures because he was sedated with fentanyl and midazolam, also known as Versed. Midazolam or Versed is a benzodiazepine, which is a drug preventing seizures, but it's also a strong sedative designed to keep patients in intensive care in an induced coma when given in high doses and through a drip intravenously. Now that your dad is having a tracheostomy, he won't need the midazolam or Versed and the fentanyl any longer because he has a tracheostomy, because it's so much more comfortable and easier to tolerate. Therefore, your dad is more awake and therefore also more prone to seizures. The next thing they need to work out is to find the right dose of Dilantin or phenytoin, Keppra, also known as levetiracetam, and Vimpat to keep your dad seizure-free if possible at all. They will hopefully be able to work that out over the next few days. Ask them about their plans. Now is also the time to ask for your dad's ventilator settings. It would be ideal if you can even send a picture. Also ask for his arterial blood gas results, also known as ABG, and also ask for his chest X-ray results. If you could send me some of that information, it would be great, so we can determine how quickly your dad can be weaned off the ventilator. And if you've watched so far, go and have a look at my one-on-one consulting and advocacy sessions on the top of the website and select from the options that work best for you. Now, carrying on here, James writes back, Hi Patrick, My father is doing pretty well today, all things considered. His eyes are opening and he has a GCS of 11. He seems still very weak, but hopefully he is aware of his surroundings. He goes for the tracheostomy a lot. They are going to stop his Vimpat tomorrow in preparation for moving him to LTAC, which is again long-term acute care. He will need help weaning off the ventilator. I would like for him to stay in the ICU as long as possible. And I also wanted to discuss the ways of stalling him going to LTAC. I know he can't stay there forever, but another week in ICU would be ideal, I believe. I feel he's getting very good attention and care, and he's making good progress, and I don't want anything to interfere with that. Thank you, from James. So here is my response. Hi, James. That's pretty good news for now. GCS 11 is the maximum anyone with a tracheostomy can score. From that perspective, he's doing pretty good, and reducing Vimpat might have been the right thing to do as long as he stays seizure-free. And if you are wondering what GCS stands for, it stands for Glasgow Coma Scale, and it's a neurological assessment tool. We discussed this in our last consulting session in more detail, so just click on the link to the last consulting session and you can get me more information about GCS or Glasgow Coma Scale. So James, as discussed in our last phone call, LTAC or long-term acute care, I believe would be a disaster for your dad because his level of care would drop significantly. He would lose the skills, expertise and professionalism that intensive care professionals bring to the table. No such thing exists in LTAC, and the needs for your dad, as long as he stays on the ventilator and tracheostomy, are that he needs ICU nursing staff and an ICU doctor. LTACs are designed to empty ICU beds quickly without looking at clinical needs. ICUs are so busy and they need their beds urgently, which is one of the reasons ICUs want to do a tracheostomy at the first sign that weaning off the ventilator and the breathing tube takes longer than their financial budget allows. That's an absolute tragedy, and money or perceived funding available should never dictate clinical care. Clinical pictures, diagnosis and prognosis is what needs to determine clinical care and treatment. Think about it. In LTAC there are no ICU nurses. Often there are nursing aides looking after your dad on life support who just spent 4 weeks in ICU at the brink of death. Furthermore, LTAC stands for long-term acute care. Now, James, think about this. This implies long-term. What a nightmare for anybody on a ventilator and tracheostomy. Nobody should be long-term ventilator and tracheostomy dependent. The only reason a patient ventilator and tracheostomy dependent should leave ICU is to go home with a service like intensive care at home. Then your dad would still be looked after by intensive care nurses. Again, LTACs are designed to save money, reduce the level of expertise and skill, and still keep ventilating patients long term. LTACs simply don't have the same level of skills and expertise compared to ICU or to a service like intensive care at home. The longer LTACs can keep their patients, the more money they are making. Why isn't LTAC named STAC, like short-term acute care? That would put the pressure on to try to wean patients off ventilation and tracheostomy as quickly as possible. Now, in ICU, the pressure is on, and they can usually also handle it with the expertise and skill the doctors and the nurses have, including the respiratory therapists. The goal needs to be for your dad to stay in ICU, and as I mentioned, keep pushing them to keep your dad there by asking them all the right questions we discussed on our call. Again, just keep focusing on things like continuity of care, skill level in ICU compared to LTAC, and keep mentioning that you just don't feel comfortable with the LTAC they have offered you. I cannot tell you how many families call us here at intensivecarehotline.com who want to get their loved ones out of LTAC. I think what we'll do next is to get on the phone again and speak to the head doctor of the ICU and talk to him. Set up a meeting and I will make myself available. So, how can you become the best advocate for your critically ill loved one? How can you make informed decisions, get peace of mind, control, power and influence quickly whilst your loved one is critically ill in intensive care? You get to that all-important feeling of making informed decisions, get peace of mind, control, power and influence when you download your free Instant Impact Report now by entering your email below. In your free Instant Impact Report, you will learn quickly how to make informed decisions, get peace of mind, real power and real control, and how you can influence decision making fast whilst your loved one is critically ill in intensive care. Your free Instant Impact Report gives you in-depth insight that you must know whilst your loved one is critically ill or is even dying in intensive care. Sign up and download your free Instant Impact Report now by entering your email below. In your free Instant Impact Report, you will learn how to speak the secret intensive care language so that the doctors and the nurses know straight away that you are an insider and that you know and understand what's really happening in intensive care. In your free report, you will also discover how to ask the doctors and the nurses the right questions. Discover the many competing interests in intensive care and how your critically ill loved one's treatment may depend on those competing interests. How to eliminate fear, frustration, stress, struggle, and vulnerability even if your loved one is dying. You get 5 mind-blowing tips and strategies helping you to get on the right path to making informed decisions, get peace of mind, control, power and influence in your situation. You will get real-world examples that you can easily adapt to your and your critically ill loved one's situation. How to stop being intimidated by the intensive care team and how you will be seen as equals. You will get crucial behind-the-scenes insight so that you know and understand what's really happening in intensive care and how you need to manage doctors and nurses in intensive care, and it's not what you think. Thank you for tuning into this week's Your Questions Answered episode, and I will see you again next week in another update. Make sure you also check out our blog section for more tips and strategies, or simply send me an email to support@intensivecarehotline.com with your questions. Also, have a look at our membership site, intensivecaresupport.org, for families of critically ill patients in intensive care. Or you can call me, find international phone numbers on the top of the website. Also, have a look at our ebook section, and you can also get one-on-one consulting and advocacy with me via Skype over the phone and via email by clicking on the relevant tabs on the top of the website. This is Patrick Hutzel from intensivecarehotline.com, and I'll see you again next week in another update.